Good morning, ladies and gentlemen. Welcome to a magnificent Bloody Hall. So we are very proud to have this building, and also this is the one of the ISE teaching labs, the visualization lab officially called. It's very nice to see you all here. We have a presentation schedule that is also on these handouts, which you can find on the tables here. And ultimately, it's Kusali Simon and Peter Emby, which organized this session here. We have Faith Hawkins, and she's going to say a few words later on about the Addictions Grand Challenge Phase 2, in case some of you are not familiar with it. It's my pleasure to introduce the topic itself to you. This is a so-called onboarding session. It's one of many sessions that are happening that introduce this major challenge for the state of Indiana, but also beyond the state of Indiana to larger audiences, to researchers, but also others that are interested in helping help this major disaster. I think many families are affected. The pain and the suffering that is going on in the state of Indiana right now is really something that we have to take action on. And we hopefully also can pool resources which typically are unconnected to make a difference in terms of health and in terms of this epidemic. So again, this is the title of the session and the organizers, and again, Faith Hawkins is here with us as well. How many of you have used Data USA? Can I see a show of hands? All right, if you have not used it, please go there and check it out. There are many websites out there designed by people in the state of Indiana and beyond, which really try to federate and make available relevant data sets. And it's no use to reinvent the wheel. This particular website comes with codes that's open source. So if you like some of the functionality here, you can take it and implement it for your own data sets, or you work with that team to get your data also available online. The more data sets become available to more people, the better ultimately. Some of you might have seen this overview of different types of data sets that are also relevant here. There's structured data, there's unstructured data, there's demographics, there is of course also patient data, there are lifestyle data, there are exposome data sets, and all of, or many of these are relevant for this effort. And again, benefiting from research that has happened before is really important to get to solutions fast. You might also be familiar that there are many, many different stakeholders that need to be empowered to deal with this epidemic and to truly make a difference. Some of them are mentioned here, and some of them are in the room, which is wonderful because we want that cross-fertilization. It's not just researchers talking to researchers, but it's also researchers talking to communities, to patients, to parents, to the press, to public authorities, etc. And so some of these stakeholders which we need here talking for making a difference in the Addictions Grand Challenge might not even be mentioned in this graph, but we want them all on a table because they have different means to help it. And they ultimately also need to understand what's going on, and they need to benefit also from the visual analytics insights that we are generating for different stakeholder groups. So when the different teams are presenting, I would deeply appreciate if they also mention for which stakeholder they're actually working, because it makes a difference if you do a visualization for a parent, or for the press, or for a public authority, or for another researcher. Visual analytics ultimately should be actionable, it should be usable to begin with, but ultimately in order for this to make a difference, it needs to be actionable. So if you design something that people really have no means of implementing, it might not make a difference. Ultimately, impacts should be measurable. So there needs to be a way to get to before and after data and to compare the two and to really show that your intervention made a difference. Kusali wanted to say a little bit about causal inference analytics. If you want to come up front, this way you also captured on the camera.
Welcome again to everybody. It's really great to have so many people who are interested in all these different aspects of how data can be used. And I just wanted to add a slide on where I think the visualization analytics and causal inference analytics come together, which is that visualization is really important aspect in the before, the during, and the after. It's for understanding how we should think about, what to expect. We, by visualizing, can see what trends are happening, and then together with theory can come up with hypotheses that we then can go and use causal inference methods to test whether these really are being caused rather than just co-occurring and happen to be correlations. And then visualization really also helps in trying to then communicate and say, what have we learned from this, and how can we then cycle back to thinking about what new questions these bring up. So this is just, I think, a great combination of all the different ways that data analytics come together. So we have, and now I don't remember how one clicks forward.
This is interesting.
Not that,
So I think this is where Faith gets a few words.
yes, so now should come Faith's slide. And it's, we'll just write this down here.
I'm going to back up a second and just sort of put what Kati and Kosali have spoken about in the context of the Grand Challenge, assuming for a moment that y'all you've heard the words with it, but may not know the details, and particularly phase 2. So I'm guessing that, okay. We know that this is a bad crisis, but some key points that make it something we're focusing on. Fatal drug overdoses in Indiana have increased by 150% in just a little over a decade. And fatal opioid overdoses in particular by 400%. It's a huge impact. We not only see the impact in terms of things like overdoses, but harms that are associated with addiction. And most of us are familiar with what happened in Scott County a few years ago, a county which had previously had a total of 10 HIV cases reported in a decade, suddenly in just over a year had 191 cases. Huge impacts. And of course, for every one of those cases of HIV, for every one of those overdose deaths, there are expanding impacts, the families, the communities, the businesses. This is not something that impacts one person at a time. It impacts large sets of people, which is why it's so important. And if you need a business reason to care, then we identify that the total cost of drug overdoses in Indiana tops $1 billion a year. And so take that by every year, more and more of them, and it gets more and more impactful. That's a word I hate, so just excuse me right now for having used it. So responding to the addictions crisis is a partnership between the governor, IU Health, Eskenazi Health, IU, and a growing number of service agencies, companies, and others. This is going to grow, and we are really happy that IU is at the center of it. Our investment is $50 million over 5 years. I first want to state that we know that not everything that IU does related to addictions will come under this umbrella. There's a lot more than this. But this $50 million is trying to invest in enhancing our capacity, increasing our partnerships, and expanding what we're doing with impact on this crisis. Our key primary goals with our partners, one is to reduce the incidence of substance use disorders. 2 is to decrease opioid deaths, and 3 is to decrease the number of babies born with neonatal abstinence syndrome. The reason we chose these 3 is not only because each has big impact, but because each of these is really a big basket. And in order to get there, there are other sort of sub-goals. So for instance, in order to reduce the incidence of substance use disorder, we need more treatment centers. And we need to make it easier for people to get to treatment. We could have made one of those our goals, but we're sort of looking at big goals that have lots of things involved in them. This is our model, and it's really important. We know that addiction is individual. It is biological, genetic, neurological, psychological, but it is not just that. Addiction is also interpersonal. It's about our families, the social networks we're in. It's organizational. It's about the organizations and institutions around us. Is there a social safety net there or not? Can it help or does it not help? It's also about the communities we live in, both in terms of the impact that addiction has on them, and are they resilient, and are they able to be resources in the fight against addiction. It's also about society and public policy. We know that there are laws and regulations that make it harder for people to get treatment, that make it more economical to prescribe opioids than non-opioid pain relievers. Those are policies and things. And in order to combat this problem, we have to look at all of these levels. Now, granted, I don't expect any one of you to come up with a project that is working on all these levels all the time, but the job of the leadership team, which both Kosali and Kadi are on, is to come up with a portfolio of projects that over time will be working at all these levels and try to integrate them. And if we fail to do that, we will have failed. But if we succeed, we will have succeeded in a big way. If you have not read Sam Quinones' book, Dreamland, I really recommend it to you. It is accessible and very stunning. But a parent of a young man who died of an opioid overdose at one point says in the book, nobody can do this on their own, but none can stand against families, schools, churches, and communities united together. That's at the core of this grand challenge, is that recognition. I don't know why that's doing that, but basically, I'm really sorry. Data people, help me. What you don't see there is a Venn diagram with 5 overlapping areas. That is so irritating that I'm going to get rid of it. But the 5 overlapping areas that what we decided was, where is IU good? There are things we are not terribly good at and we shouldn't be trying to do them. Let's leave that up to people who are better at it. But where are we good? And the 5 overlapping areas where we are good and we can use our abilities are data analysis and data sciences. That's area 1. Education, training, and certification, both of people currently training to be doctors, teachers, etc., but also of people already in the field. Policy, economic analysis, and law. Basic, applied, and translational research. Everything from looking at the neurology of addiction and the neuroscience to treatments and comparative effectiveness of whether or not those treatments work. And community and workforce development. Some folks talk about those as pillars. I don't like that because it suggests that they're working separately from each other, hence a Venn diagram that lost something in translation. Again, we don't anticipate that any one project will be working in that sweet spot right at the center of a Venn diagram involving all those areas, but we hope that many projects will be in overlapping areas and that together we will create a portfolio of work that is in all of those areas. So far, we've identified 16 shovel-ready projects that began their work in January. We're in ongoing conversation with federal and state legislators, officials, and other agencies, and we have had scores of contacts from companies, agencies, other schools, people around the university. This is our 3rd grand challenge, and I will tell you that none of the things we've announced in the last several years have had this kind of uptake from the community. It tells me that we have stepped in probably a little too late, but nonetheless stepped into an area where people know that this is really important and we need to have an impact. A quick phase 2 overview. Number 1, if you are a core campus faculty member or academic appointee, you can serve as a primary investigator on a project proposal. If you are a regional campus faculty member, other staff, community partners, you can serve as key personnel. The total funding available for phase 2 projects, which will be announced this fall, is $16 million. We anticipate that no project will request over $2 million for a 4-year period. To give you a sense of where we are, those 16 projects that were identified earlier last fall and started their work in January have a total budget of about $12 million. Some of them are really big, some of them are really small. All are guaranteed to have important impact. The timing. Optional concept papers are due April 5th. These will not be reviewed for scientific detail. What we're looking for here is to guide you Are you in scope of the Grand Challenge? Do we see opportunities for you to partner either with colleagues across the university or with community partners outside the university? And do we see that this is something that is likely to have impact? We don't want any faculty members to spend a lot of time on something that is really just not going to be competitive. And by in scope, I will say, if you contact me and say, I am studying the science of gambling addiction, I will say, have a good time doing that. It's really important, but it is not in scope. And so that's where a concept paper would be helpful for me to give you that kind of feedback. Full proposals are due June 25th, and we expect implementation to begin in late September. My last point is that a couple of events like this one, you can work independently and never talk to me again until June 25th, and that is fine. Many people will do that because they know what they want to do and they know how to set it up. But for those who want to take advantage to try to develop interdisciplinary teams, we have lots of opportunities for you to do so. The two that are upcoming this week, scoping sessions, where people will try to reframe their understanding of the challenge and get a new sense of whom they might partner with in order to work on it. And then in May, we are doing a 3-day intensive residential in New Harmony, Indiana, to come up with projects that are interdisciplinary in scope and in personnel. You have to apply to participate in that, and you can go to grandchallenges.iu.edu to do so. That's sort of a quick overview of why we're doing what we're doing, how we're doing what we're doing, and how you can get involved. Are there any questions about that? If you have not signed in on the very fancy schmancy sign-in sheet that's going around, please do so that I know who you are. If you have any questions at any time, please email either grandchallenges@iu.edu or me personally, fhawkins@iu.edu. Thank you for your interest in this. Thanks for helping us make a difference for the people of Indiana.
Thank you. So we have 7 presentations, and all presenters promised to stick to their 5 minutes. And I'm going to time them, and I will try to move them off the stick, or I will come very close to them if they don't stick to it. So Andres and Jason came also from Indianapolis to present what HC1 is doing in collaboration with Teachers Live. So if you would like to go up and present, these slides should be right after this slide.
Okay.
So if you hit enter, I should just go forward.
Thank you. Good morning, everyone. My name is Andre Speaker. I'm with a company called HC1.com. We're on the north side of Indianapolis. And to help you understand a little bit about what the visualizations and some of the analytics that I'll give you examples of, I do want to take a step back and help you understand what we do as an organization so that you can understand where we get the data from. I'm not sure if you are familiar with HC1 or not, but we are a leader in what we call healthcare relationship management. So, you know, the concept of CRM, Salesforce.com, Microsoft, et cetera, taking that to the standpoint of understanding healthcare relationships better and all the complexities that go into healthcare relationships. And so we've built a platform that helps healthcare organizations, and in this example, laboratories, manage their own operations by getting real-time access to the data, understanding how to operate more efficiently, how to manage their relationships with their clients, how to maximize their business. And so with the different pillars that we have as part of our platform, the information services side, the HRM or healthcare CRM essentially, and then analytics. The analytics and information services is kind of where this comes together, and the core of our data is in working with these laboratories, we build real-time integrations directly into their laboratory information systems. And so we're ingesting all this real-time clinical data, high fidelity data that we can then, is part of the technology that we've built, aggregate across all of our different clients, de-identify the data, but also normalize the data. And in this case, a large portion of our business is actually coming from laboratories that do toxicology testing. And so with all these drug tests, being able to normalize that data, because the same 22 panel drug test might have different nomenclature across different laboratories and different clients, being able to normalize that, but again, the de-identification of it to really understand the data. With all of that data, we've ingested about 5.2 billion, and that number grows exponentially every day. Total diagnostic results across our database. We're covering all 50 states with 51 million individuals. And the reason, in this case, being kind of healthcare related, that we don't call them patients is because of where our data is coming from. And so the different clients, the different laboratories that we work with really cover a vast array of industries, from clients that are doing specifically pain management testing on the toxicology side, general reference lab testing that might include some drug testing as a part of normal healthcare procedures. Then the final piece would be actually working with some of the largest labs in the world that do workplace testing, criminal justice testing, and also regulated industry. So like the trucking industry that requires drug testing for every 6 months. And so it's a lot of data that's coming in that we have visibility to. And what we put together, and we have clients that are actively using this, is being able to measure the positivity rate. So when you do the drug test, are you positive or not? What drugs are you positive for? And giving you access to that. And again, the key piece, one of the key pieces to this is the normalization of the data, but also the fact that this is truly in real time. You're not relying on data that's a year old, where 2018, let's look at what 2016, what the story was back then. It's what did yesterday look like? What did last month look like? Where are the trends moving? And as you can see, being able to look here in the state of Indiana, by county, what those positivity rates are, where we can actually filter over here to look at what are the different drug classes that we're focusing on. And certainly opioids are the big focus here, but being able to compare use of opioids with benzodiazepines that are a big problem as well. Other drugs where you can start looking at visualizations of what the trends look like. Are we seeing an increase in a certain drug class where we see a decrease in another? Or are there situations where those drugs are being switched over? We can see the positivity by drug compared to what % of the population is being tested for it. Faith mentioned certainly the case in Scott County. And so as we look at this data, and this is something we're kind of continuing to dig in deeper into the data itself, but it kind of allows us to tell that same story and identify that with this kind of data, there are ways that we can potentially help identify early warning signs of something like this happening again. And so as you can see in the early parts of, or later parts of 2014, early 2014, 2015, the positivity rates in Scott County of opioids and drug use in general were pretty high. Those numbers did drop as the AIDS crisis started increasing there. And one of the things that we're interested in looking at is, with all the other clinical data that we have, if we can start identifying correlations between the toxicology data and communicable disease or other states that can help us tell a story where we can maybe potentially help avoid a crisis like this in a specific area by looking at the numbers and identifying, being able to be a little more predictive on it. Another way that this can be helpful is looking at where those positivity rates are. And so these kind of weather maps that you're seeing are actually looking at fentanyl positivity rates. And as you can see, over a 3-month period, the numbers actually go around Indianapolis, where Marion County itself actually stays low positivity, but you're seeing the positivity rates go. So again, different ways that that public organizations, social service organizations can really start using this information to identify where the trends are, what are the drugs that are coming into the area, what are the usage trends compared to what's being prescribed versus what's actually being used. Being able to look at information in real time versus relying on overdose data when it's too late, on death data when it's already too late. So those are some of the things that we're doing to try to help, and certainly appreciate the time today.
Thank you.
Any questions? Yes.
Can you talk a little bit about how do you distinguish between positive drug tests for people who are prescribed medication versus those who aren't?
Sure. So there are now on the workplace testing, those are either positive or negative. Those don't really come to say, hey, I have a prescription for this. And certainly that's going to continue to change. On the healthcare side, on the side of actually pain management, those typically do come in as the order for that drug test comes in will show what the patient is expected to be positive for. Now, in these visualizations, these are visualizations that the state of Indiana actually has access to, and they, in this case, we're not separating what should be positive, what shouldn't. And that's one of the reasons why we have the filtering capabilities, because if you filter for opioids and hydrocodone, you'll actually see most of the positives come from general toxicology, probably expected. Now, some of those can vary between what the amount that should be expected versus not, and that can also vary by client. But being able to break away from that to say, okay, and looking at what the heroin trends look like, what fentanyl, other areas that aren't the ones that are being prescribed and things like that, I think the real value where you can differentiate between data and a PDMP, a prescription monitoring database, and what's actually being used on the illicit side, on the side of things that really aren't being prescribed on the street or in those scenarios where you can really start looking at correlations and differentiate that. But that's a good question.
Yes. Very good. In the interest of time,
Okay.
so that everybody gets to present, we might have to cut it off to you.
Okay.
Thanks so much again.
Thank you very much.
Our next one on the list, and I hope you all got an agenda, there are more on the table here, together with cookies and everything else, is Chris Hall. And he's one of the 40 in the state of Indiana under 40. So this is a true treat that he actually is going to present his work to us.
So what I'm going to talk about this morning is our work we've been doing now for the past 4 or 5 years, looking at user-centered decision support for chronic pain and opioid prescribing. And this is some work that I started when I was down at the University of Florida and have now moved on to doing here through a couple of grants from AGC for research, healthcare research and quality, HRQ, as well as now funding from the NIH and NIDA. There we go. So our focus mainly when we talk about what decision makers we're talking about, what kind of data we're talking about, we're looking at primary care pain management primarily. And so we know from the Institute of Medicine and others for a long time that taking care of chronic pain is really, really difficult in a primary care setting. Patients with chronic pain, that's where they tend to go. They tend to go to a primary care physician or other primary care provider. And now this has been particularly challenging in recent years as we've realized that the medications that clinicians have been relying on for many, many years, in many cases, the risks are going to be outweighing the benefits. And so that's been our focus. And we take a very user-centered approach to our design. We go to the clinicians, we go to the healthcare settings, and we spent the last couple of years observing clinical practice and talking to clinicians, in-depth interviews around decision-making processes, around information needs, and as well as just literally audio recording doctors and patients when they talk about pain and when they talk about opioids. So we're now at around 20 clinicians and 70 plus interviews, asking these kind of questions that you see on the slide here. So how do patients and clinicians interact during visits around chronic pain? Where do clinicians struggle when making decisions? What information is missing? What information is needed? And then also talking about technology. So when do electronic health records help? When do they hurt in this process? And our goal is to build better technology and then evaluate it to see if we can truly improve outcomes, if we can truly improve clinician experience, patient experience as they are treated for chronic pain, including the use of opioids. So we've been going through this process and we're now in a phase where we have identified some pretty, what we consider key decision requirements for our designs, and we're in a design phase and we'll shortly be in implementation and evaluation of some tools. So what I'm going to show you this morning are just a few slides of early designs that we've come up with. And the main one here we're going to talk about is our opioid one sheet. And so again, the level of analysis here, which I think may differ from some of the other visualizations you're going to see this morning, we're talking about individual patient data being presented to an individual clinician, a primary care physician, for example, a nurse practitioner, for example. And the components of this one sheet, which I'll walk through briefly, they represent a couple different things. They represent user needs, information needs, and the key decisions that we've elicited from all of our interviews and observations. And then they also map fairly well to CDC guidelines from 2016 for chronic opioid prescribing, the kinds of decision tasks that are needed in order to follow recommendations. So I can kind of walk you through from left to right and down. One of the primary pieces in CDC recommendations and primary places that clinicians struggle with is really identifying goals with their patients and then actively measuring things like pain and physical function. And so the first piece of our opioid one sheet is meant to provide and this entire thing is meant to provide sort of a one-stop shop for all of the relevant information that one might need in an interaction around opioid prescribing. So the first point is to provide some easy to access information around patients' function and pain, right? So that we have more outcomes-driven treatments. Over here, when you see factors to consider, these all represent different elements that help a clinician look at risks and benefits around opioid prescribing. So you can talk about identifying opioid-related aberrancies, potential medication interactions, for example, opioids interacting with benzodiazepines. All of this in current form is meant to provide sort of a red light, green light sort of visualization around increased risk or decreased risk based on the absence or presence of these sort of things. So medication interaction, psychiatric history that might indicate increased risk, things like urine drug screen results that could indicate misuse of the medication, opioid dosing. So the CDC guidelines are going to tell us that as we go above 50 morphine milligram equivalents per day, we're at increased risk of bad outcomes, as well as when we jump above 90 morphine milligram equivalents. So the same sort of red light, green light presentation to indicate when we're at higher doses of opioids. And then we could do something similar with side effects. So goals, risks, as part of the calculus when a clinician's trying to decide whether to prescribe opioids or not prescribe opioids, continue opioids in a patient with chronic pain. And then we're meant for the one sheet to also be a place where they can more quickly do the clinical tasks that they need to do. State law and clinical guidelines are going to tell you need to do prescription drug monitoring reports on an annual basis typically, or maybe more often. So trying to place one place into the electronic health record that a clinician can get that PDMP report ordered and viewed, doing things like discontinuing meds that may be interacting, ordering urine drug screens when due, and these sorts of things. So this is meant to be, again, kind of one-stop data aggregation for a given patient. And then what we envision beyond that is sub-screens that can be drilled down to, such as the ability to trend patients' pain and function over time in correlation with the medications they're on. Indiana is in the process right now of integrating electronic health records with the INSPECT prescription drug monitoring program. And so we see these as all offshoots of our primary one sheet for clinicians to look through as they're treating patients. And I'll stop there.
Clarifying questions like facility traffic seem to be presenting virtually. Any questions?
So I've encountered the DNA tests that I'm not actually sure exactly what they're testing for. They're testing essentially for liver uptake of different kinds of medications, including psychiatric medications, but also opioids as well. I'm wondering if you're familiar with that, and if that can be a part of there are some drugs that some people respond to and some that they don't, and giving them the wrong opioid prescription that they don't metabolize very well to do that.
Yeah, so there's any number of opportunities to kind of build in risk models. So they may be, so we know certain genomic polymorphisms relate to metabolism of, say, codeine. So any of those things could be built into this. We've focused the requirements mainly around what the clinicians say they need and what the guidelines say, but that's not to say that we couldn't, if we can get good prediction or we can get good measurement of risks, we could put that in there as well.
I guess I'm wondering as much as whether or not it's like really been uptake, whether there's much uptake in clinical practice and using that as a screening tool for dealing with patients.
No,
so that you're prescribing, but you're not doing it.
Some of the needs in clinical practice right now are so basic. Why we're not even close to that for your typical clinician. It's how long have they been on opioids? What have we tried before? What exactly is their chronic pain diagnosis? These are things that clinicians don't even have at their fingertips. So.
Could you go back to the one-page thing? I'm wondering if there's a reason why you have the factors above and the to-do, as opposed to, since this is a visualization format, why you don't have them as two columns with the, I wasn't sure what you were going for there with the red, green, and yellow, but then when you described it, you know, that works so well at NIH, but if you did it as a column, if you did it as two columns, you could actually set it up like the stoplight, which I think would be more visually resonant for physicians.
Absolutely. So all this is on the table where we've got the next year, a whole series of evaluations and user studies to do for sure.
A request from the Zoom participants, if you don't mind repeating the question. When you hear a question, go ahead.
Okay.
Very good. In the interest of time, thanks so much.
Sure.
Chris.
All right, if you can go ahead and kick off to the second slide, that'd be wonderful.
Next slide first. If you go to the next slide. And now to the next.
Next slide, please. Okay, so everybody in the room kind of knows that Indiana has had this huge increase in terms of opioid-related deaths. It's over 570% since 1999. Really, from Management and Performance Hub's perspective, our goal at the state is to break down the information silos across state agencies and try to give policymakers, researchers, government agencies the big picture view of the problem. Right now, as part of our drug data working group, we have 10 agency partners, and we have a continually building a user story bank where we're at 66 user stories, but we just added about 8 more this past week that we continue to try to answer through dashboards and outcomes. So next slide, please. So our achievements over the last year, we have created 8 visualizations or dashboards or weekly alerts for the governor's office and those agencies as part of the drug data working group. This includes dashboards related to opioid-related deaths in the state, LIMS, which is Laboratory Information Management System from the Indiana State Police, and that looks at drug seizures across the state. We also have emergency department visit alerts, which are sent out weekly through our agencies in the governor's office. We also have an inspect dashboard that looks at prescriptions across the state. And we've actually taken inspect, the death records, the emergency department visits, and the EMS run data and linked all those together across individuals in the state and have provided a comprehensive dashboard for those individuals. So that's really what we've kind of done to this point. Some of the upcoming things that we have as far as data acquisition is we're starting to implement arrest data and Medicaid data and DCS data, looking at parent toxicology results, along with the methadone treatment center data and DOC prisoner data. This is all going to be implemented into our drug data warehouse, where we are linking everybody in that warehouse across all of those data sets so we can provide a comprehensive view of individuals as they touch all the different arms of state government and across different counties and so forth. As we do this, we are working on supporting all these agencies in their data quality initiatives and assisting the state as we can in implementing new technologies to help them. We also, obviously through this, are partnering with researchers and community stakeholders, and then with the end goal that we can make as much of this as publicly available as possible, hopefully in the very near future. So next slide, please. So right now, really the only dashboard that we're able to share outside of the data working group is our LIMS dashboard. So this just gives you an idea of what the state and the data working group is able to look at. Again, this is drug seizures. The map on the left you could see is to a specific year by county. You can see the trend line graph on the right, looking at the different DEA groupings over time. And then you can see a table down below. If you look in the table, you can see trends of marijuana or stimulants. Of course, then the opioid trend, which is second from the bottom, I believe. You can see that trend upwards. Next slide, please. This one here just looks at that state map over time. And now we're looking specifically at opioids. And you can see the trend of fentanyl in 2014 and 15, and then the spike in 16 and 17. Currently, LIMS has about a 100-day backlog. So this doesn't quite capture the end of 2017, so that number would be slightly higher. You can also see heroin as well, methadone, and then morphine. So this is just kind of a good overview example to show you one dashboard out of many that we've created for state and state agencies. And again, hopefully in the near future, we'll be able to share some of these more with the public or data sets that are involved in these and so forth. Any questions? That's all we had in the 5 minutes.
1.5 minutes, I have some. How many of you have been at MPH or have visited?
Apologies, it's hard to hear from I think the rest of the crowd. You may need to repeat the question.
Good morning, this is Kati Warner. Thanks so much for staying on time. You're the first team that actually makes it before my gong rings here. So I was just asking the room how many have visited MPH or have interacted with MPH before. So we have about 8 of us. So you are getting more market penetration here. Very good. Do you have events coming up, right? You have the data day coming up.
We do. It's next Tuesday. So yeah, thanks for the plug there, Kati. It's really helpful. Next Tuesday from 10 a.m. till 2 p.m. we're hosting what we're calling MPH Data Day here at the state. It's on the main floor of the State House, on the north end of the State House. So we got that whole half of the State House over here where we're going to be, showcasing all the cool things that people are doing with data, both within the state and outside the state. So Kati and her team are going to be bringing a really impressive kind of data visualization display to really kind of talk about, the future of data visualization and where, if we continue to go down the path of what we've been doing, where we can actually head to. We've got different agencies from FSSA and State Department of Health and Department of Education and Commission for Higher Ed, and of course, the Drug Data Working Group, and specifically Tim George from the Governor's Office speaking to it. Just kind of talk about a lot of the key projects that are happening and really just trying to create a level of energy and excitement around the concept of data-driven decision-making. We're really kind of trying to drive that culture from the inside out. And obviously all the partners are coming in, from IU, from a number of different entities. I mean, I think PPI, Polis, IBRC are all going to be, plugged in as well. Obviously it just kind of continues to add credence to what we're doing.
Very good. And if you want to tweet the link, that would be great. I already tweeted about this event, so you could just follow up on that. Faith, do we have a Twitter hashtag for the addictions?
We don't, because I am firmly in the previous century.
Okay.
So, but we'll get one.
All right, wonderful. Thank you all, and thanks so much to the MPH team. All right, next one is Freya Perry, and she is here in the room, which makes it so much easier. But thanks for presenting virtually. Thanks.
Oh, sweet. All right, great. So I'm here to talk about an NIH-funded project that we have that really focuses on one drug-seeking behavior, doctor shopping. And so my collaborators on this are Jeff Tauber, Trish Freeman, and Carrie Oser at University of Kentucky, YY On here in informatics. And this really is an interdisciplinary team spanning sociology, criminology, informatics, and pharmacy. So if you don't know what doctor shopping is, it is the practice of obtaining controlled substances from multiple healthcare practitioners simultaneously, exceeding the recommended dosage. And so typically this involves going to multiple doctors and manufacturing symptoms in order to procure opioids. It's really common. About 40% of people who are addicted to opioids engage in doctor shopping practices. And research suggests that it's a really important behavior in terms of early identification of addiction because it indicates an escalation of drug use, and then it also is a really strong predictor of future overdose. The problem with this drug-seeking behavior is that it's very difficult to accurately identify. So currently we have these thresholds that we use. So for example, a very common one is the 4+4+90. So you have seen 4 or more providers, gotten 4 or more prescriptions, and also gone to 4 or more different pharmacies in a 90-day period. The problem with these kind of thresholds is that there's a lot of type 1 and type 2 error, right? So it picks up a lot of, for example, cancer patients who are engaging in palliative care. And then it also does not pick up a lot of low-level doctor shoppers before they begin to ramp up their addiction. So what we really want to do is be able to identify these people earlier using better indicators. So although it's really difficult to accurately identify, doctor shopping is fundamentally a social drug-seeking behavior. So there have been some really interesting small qualitative studies where they've shown that people share information about who the best targets are, who the writers are, who they can get to prescribe them drugs, either because the doctors are fraudulent or because they're easy to dupe, essentially. So we put this grin in order to take a social network analysis approach to try to create better indicators of doctor shopping earlier in the addiction trajectory. So the specific aims are to improve the specification and predictive validity of doctor shopping indicators by incorporating social network measures. And so we think that it's really more about which actual providers you're targeting than it is about how many targeters you're providing, right? So if you're somebody that goes to 4 random providers, that may be less meaningful than if you're targeting 4 very central, very active prescribers who are prescribing to lots of other doctor shoppers. So once we've created these better network measures, the next goal is to identify characteristics of doctor shopping patients, targeted prescribers, and the point of service in order to inform interventions. So we purchased the Optum Clinformatics data set, which is all health claims from 2007 to 2016. So we have these measured quarterly, and we're integrating medical, pharmacy, facility, and laboratory data. We have about 21 million patients who ever had a controlled substance prescription, which is about 40% of the total in terms of coverage of their entire patient population. We have nationwide coverage, we have ZIP-5 data, we have the ability to link family members together, and also to link across unique providers or link across patients to the same provider. So in other words, we can create network data. We also have mortality and SES data. I'm describing all of this because we are willing to share with IU researchers who have similar goals. So what we're doing is using this to create social network data. So you have your standard 1-mode network data. This is a 2-mode network where you have nodes that are in different classes, doctors and patients. And then we can also then create a weighted 1-mode affiliation network here on the right. And so Pat, in the short amount of time, this is my RA, Patrick. He created these beautiful visualizations, which are somehow out of focus, but he's going to tell you really quickly what they are.
Okay, so this is for the first quarter in 2016, and this is a doctor network. So doctors are linked through shared patient prescriptions of opioids. This is a K-Cord 5 reduction. This is a K-Cord 2 reduction. In this case, it means we have only doctors who have at least 5 ties to other doctors. And what we can see here is that there's a lot of doctors who are linked to other doctors in the same state, so no state crossing ties. In this network, we can see I excluded all of these ties and only looked at the ties where doctors share patient across state lines. And this is an important phenomenon that is observed in doctor shopping, that people tend to cross state lines in order to avoid detection by PDMPs. So here you can see there's a lot of state line crossing going on. And that's it.
Thanks.
Perfect timing also. The next presentation is virtual, and if everything goes well, they should be able to unmute themselves and just start presenting. And it's going to be David Goldenhammer and Sharon Candris on cluster mapping the opioid network in Indiana.
Hey, thank you. Can you hear me?
Yes.
Great. This is Sharon Candris. Do you have these? Okay, great. Appreciate the opportunity to share what we've been doing here. I'm the Associate Director at the Polis Center, and David Bodenhammer here is here as well. He's the Executive Director. Go ahead and go to the next slide, please. Quickly want to give some background. We are collaborating, IU is collaborating with the state on something called the Indiana Data Partnership. And that collaboration really is intended to increase the availability and utility of data shared among state agencies, but also outside of government to connect up with local government and other nonprofit data. So there's many facets to this, one of which Darshan kind of talked a little bit about was exposing some of the state data. But our effort today to kind of share with you is a cluster mapping effort, which is one way to tap into that network of data that's out there and untapped to understand important issues, particularly the opioid issue. Next slide. So just to kind of outline the problem we're trying to address here, and we kind of talked, different presenters have talked throughout that this really is, it's a complex issue, and we really need to get a handle on the scope. We know that it goes beyond the individuals. Caddy presented that whole network of stakeholders that are engaged or should be engaged in this process. And we understand that the solutions really must be multifaceted. They must be multi-sector and reach across that. Part of the challenge is that we don't know who's all out there and who's available to provide services, and that network isn't well documented. It's not easy to navigate. And when we talk about that network, we're talking about service providers. So that's government agencies that provide service, but also that nonprofit sector that does wonderful work that may or may not be well connected with others that could be providing complementary services to help the individuals and families that are dealing with the opioid addiction. So we also know there's a lot of data that's out there, but again, if we had access to that data, it would really help kind of pinpoint what some of the best solutions might be or could be, but those data aren't easy to access or find. And we can't just depend upon what data is out there from the state or from these easily accessed data. So we need to figure out how do we tap into those data that are held by the service providers. Next slide. So we're taking, oh, I uploaded, sorry, okay. So we're taking an approach where we look at a solution to this by mapping, using cluster mapping to figure out who's out there doing what. We'll use this network once we have it to kind of figure out where some of those gaps are and pinpoint, excuse me, what some of the, what data might be behind some of those nodes. So the first thing we're doing, and this is kind of a process, but the first step is to map out this cluster of actors that are involved at different scales. That could be different geographies, it could be state level, local level, regional level, but really who's involved currently in addressing the opioid issue. And then identifying who's out there that could be involved but isn't already. And again, here we're talking not just mental health addiction services, for example. We're talking a whole variety of service providers that would be addressing the issues related to the individual, the family, the communities, and all those stakeholders that would be involved in coming up with these solutions. And then through this process, we can also identify those that could be working together but aren't. So who also is out there that could be connected in and providing services in ways that aren't currently. And then based on what we know about some existing models and success, who is most likely to be involved. So even if there's organizations out there that maybe aren't currently linked in, but there's others we'd want to focus on that are most likely to be involved. So next slide. And what we are trying to do is use this this graphing or cluster mapping approach. This isn't what the actual model is, but it's just a communication device here. But imagine if each of these nodes that you see here were an organization or agency that provides services to individuals or families. Again, these would be multi-sector. So the lines between them would represent the connection or relationship maybe that they already have between each other. These nodes could be color coded to represent different attributes, and then they could be clustered based on those attributes. So for example, we could code these to show whether or not they are a health provider or an education provider or some other kind of service. So we have some kind of a classification structure, maybe what sector they fall within, what geographies that they serve. We could also tag it into what kind of entity it is, whether it's government or nonprofit, for-profit, maybe university or other kind of service. So there's all different ways in which we can configure this information about agencies to help us kind of explore the network of providers that are out there. And then once we do that, then we can start to tease out, okay, once we have a better understanding of the individuals and of kind of this network of organizations, and we'll lay on that our understanding of the nonprofit, excuse me, our understanding of the opioid issue. So we could tease out from here, again, who is currently involved and who could be involved in the network, and maybe identify where some of those gaps are. Next slide.
And you are out of time, but please finish up.
Okay, I will wrap it up quickly. Basically, we are focusing on 3 counties initially. We're going to compile data about organizations and service providers based on resources that already exist. For example, our Savvy Community Information System has a wealth of data about health and human service providers. The Indiana Business Research Center has data about organizations receiving federal funding, and a nonprofit database that Kirsten Gronberg has developed. We're going to integrate those together. We're going to work with a group that's identifying some, well, the next step then would be conceptualizing the framework of the opioid model. So, or developing a conceptual framework. And that's where we kind of define who are the actors it could be that are addressing the opioid issue, who can be involved, to kind of identify that provider network that would help us kind of get that starting point. So if we've got kind of a fairly comprehensive network out there of all the organizations that exist, and then we kind of lay on top of that who's already involved in opioids, and then who could be involved in opioids could emerge from that. So we can start to identify some of those gaps and really think about this issue from a different perspective. And yeah, I think that, I mean, I'll just stop there.
Thank you. Are there any, let's clap first. Well done. Any quick clarifying questions? Online, probably there are also no questions. So of course, Alex, also watching online. If you have questions online, I saw that there are quite a number of people watching on Zoom. Feel free to send those questions in as well. All right, in the interest of time, we are going to go to the next presentation. And that's by Brad Ray, also a virtual presentation. And Brad, you would have to unmute yourself and just start talking.
Can everybody hear me all right?
Yep.
Yes, very good.
Hi, everybody. My name is Brad Ray. I am a sociologist by training, and in terms of this opioid epidemic, I focus largely on overdose and overdose prevention. As a researcher in this area, I'm concerned that as we continue to put so many resources towards this, that we might not have accurate data to measure the effect or the impact of the spending. So if you wouldn't mind going to the next slide, please. I'm the person that did that. So as you may or may not know, Indiana is notoriously bad at collecting overdose data. And I don't want to get too much into the policy weeds on this, but it's essentially because we have what's called the decentralized coroner system here. So in Indiana, coroners are sort of have their own little kingdoms in each of these counties, and rather than the state medical director. And as a result of this, we are consistently ranked in the top 5 states that use this quote unquote unspecified code. So this is somebody's died of a drug-related poisoning, but they don't specify the various substances in there. Just to give you sort of a scope, this varies quite a bit by states by this policy. So Connecticut, Rhode Island, DC, for example, have less than 1% of their cases are unspecified. So as you can see there in Indiana, about over half for many years are unspecified cases. So we don't, when we look at CDC data, count them as quote unquote opioid involved. If you wouldn't mind going to the next slide, it's a transition thing. So as you can see, the problem is the same here in Marion County, where we have a lot of our drugs being coded as unspecified. So One way to get around this in corners, the guidelines are to report whenever there is an opioid detected in the toxicology report. So one way to get around this is to actually examine the toxicology data, which is what my research team here has been doing. So next slide, please. So with this toxicology data, what we're able to do, one of the studies we did recently was we actually looked at all of those unspecified cases in Marion County, and we found that over 80% had an opioid detected in them. So we were massively undercounting the number of opioid-involved deaths that we have here in Indiana. And we've also, with this data, we're able to track more specific substances that don't have an ICD code for them. So for example, as we talked about before, fentanyl. So if you could go to the next slide. With fentanyl, we're able to look at, these are detections of fentanyl, so these aren't necessarily mutually exclusive cases. And again, as people have pointed out earlier, we're able to track this in near real time. So we have about a 6 to 8 week lag on the toxicology reports. So here in Marion County, we're looking at near 400 deaths for 2017. That's obviously more than we've ever had. About a little less than half of those deaths, we have fentanyl detected. So with this data, we've been able to show exactly when fentanyl hit Marion County. We've been able to see where it hit and sort of what populations we're seeing these changes in fentanyl. So our next goal for this data is to quote unquote free it by visualizing it. So if you could go to the next slide. So for the past couple of months, I've been working with Jivitesh and Olga, who are part of the CNS team, and we have been working on through Tableau to create some storyboards with these data. So the first storyboard just looks at trends over time so people can see sort of what the major trends have been. But the second one off to the right, that will allow individuals to go in there and interact with it to see where there are changes, sociodemographic changes in the various substances over time. The real hang up we have right now is that we're trying to get it in real time so that individuals can see, well, how many people died in January of 2018 versus 2017, 16, 15. So we're working on that, and then also linking in some other data. So if you could jump to the last slide there. There's a couple of reasons why I think this is important. As I said, I do think that there's some issues with the accuracy of the data that we're looking to assess the impact, sorry for using that word, Faith, in this area. But also this has become highly politicized. So one of the things that we're hoping to do with this is by having a quote unquote death clock, so where you can see how many people are actually dying from this in the county, that by making communities aware of it, that hopefully there might be a little bit more action to put to do something to reduce these number of deaths. Our next steps, we're a small team, but we're ambitious. We're moving to work with other counties. So we're trying to collect the same sort of data from other counties. Ultimately want to be able to work within MPH to visualize these data so that they're as publicly available as possible. And then we're also bringing in other data. So every single time a person dies here, we get prescription drug monitoring data, jail data, and EMS data, so that we can look and create a storyboard that's more on interventions to see, which cases had these events occur prior to their death. All done.
Are there any quick questions while we are bringing in another slideshow that just was submitted to us all? Any questions out from the room? Maybe I should go a little bit away from the camera here. So what I very much appreciate about this line of work is that you are setting up a data collection infrastructure, Brad, that you showcase how it works for Marion County, and then other counties can use the same setup to also get more higher resolution and more real-time data captured in a systematic way so that this can be made available to key decision makers. Brad, it's also good that you already work with MPH. We have the HCI gentlemen here in the room, and of course they're actually from Indianapolis, so I really hope that you connect. And I think also many of you presenting today will be interested to talk to each other. And I know 1.5 hours is very, very short time to just get familiar with a very rich body of research. But we hope you get interested to now send each other's emails and go back to the slides. All these slides will be made available. Also the video will be made available. And Brad, thanks so much for presenting. Also.
Thank you. Thank you.
So we have the last presentation today, which is by Sean Granis, and if everything goes well again, then he should just be able to unmute himself and present his slides. So this first slide is up here, Sean.
Great. Can people hear me okay?
Yep, we hear you.
Awesome, great. So why don't we move on to the next slide? I want to maintain a faithful commitment to that 5-minute timeline. So the Regan Street Institute was instrumental in creating the Indiana Network for Patient Care, a health information exchange operated now by the Indiana Health Information Exchange. We collect information from over 2,000 logical data sources going back over 40 years. And that data is used for a variety of purposes. This is patient-centric data. The Health Information Exchange is called the Indiana Network for Patient Care. Its primary use case is to deliver data to the point of care for physicians to take better care of patients. That being said, it is used for a variety of secondary uses, including research and analysis as well. So the left side of the slide just illustrates the different types of data that are integrated, and the right side of the slide shows the different types of use cases that are supported. So we do a significant amount of work in population health and public health informatics with a variety of partners, from ISDH to the Fairbanks School of Public Health to health services researchers. So why don't we go on to the next slide? And this is, I'm going to be that guy too. Go ahead and keep clicking through. There's animations here. These are just some of the statistics. Go ahead and keep clicking through. There will be 5 boxes on the slide. So connected to over 100 hospitals, almost 15,000 practices, for over 40,000 providers. We're over 17 million patients now. That statistic's a little off. And then over 11 billion discrete coded results. So there's a lot of analyses we can do here. In fact, I believe that we could probably support the careers of a number of health service researchers, folks interested in studying a variety of health outcomes. Let's move to the next slide. So one of the philosophies that we're looking at is, over time, we're identifying more and more types of data. So historically, we started with clinical data, that data generated within the health system. But now we're seeing new types of very important data like genomic data. And of course, now we know that issues like opioid dependence, opioid addiction, are not just based on clinical diagnoses. They're in fact more influenced by outside the healthcare system factors such as the environment people live in and their behavioral tendencies. And we are wanting to begin to gather information related to that as well. So let's go ahead and move on to the next slide. Very quickly, we are working with partners. Dr. Josh Vest at Fairbanks is leading a project with Eskenazi Health to take social and environmental data that we are, that the Polis Center is providing, and linking that to clinical data on a patient level to develop predictive models that accurately identify patients in need of very specific types of services. So that's one example of how we can expand the use of this data. Let's go ahead. We're going to click through a variety of slides. Go ahead and keep moving through this. We've worked with a variety of partners in the past on opioids. Go ahead and keep moving forward. Here, thank you. So one of the recent things we've done with opioids, specifically in the Health Information Exchange, is we've simply built a predictive model that, given the myriad data that we have, can we accurately identify patients who are going to develop an opioid addiction? Not just are they opioid addicted, but are they at a high propensity for opioid addiction? And we've compared some results to Dufour et al. Looking at predictive models. It looks like the information in the Health Information Exchange can more accurately predict patients who are at risk for opioid addiction than what current models published can do. So we're very excited about that and very much want to work with folks and the Opioid Grand Challenge to move that forward. I think I'm close to the end. I have other slides, but I think I've made the point that there's a substantial amount of patient-centric data that need to be integrated with a variety of other sources. And the Indiana Addictions Data Common, the IADC, is a phase 1 initiative that is funded to help us think through how to integrate all of these data, working with our great partners at MPH, at Polis, at IBRC, SPIA, PPI, and others to make that a reality. So with that, I will end. Thank you. Kadi, did I come in under 5 minutes?
Anyone online? Okay. Thank you so much, Sean. Perfect timing also, deeply appreciated. I believe there will be questions later on. Again, we will make these slides available. And also going forward, you might wonder, what now, right? So we have 10 more minutes left, and that's not enough time to actually interlink all these different lines of research. Fortunately, however, Faith Hawkins' team is organizing these scoping sessions. So one more time, on Thursday, March 1st this week, there will be a scoping session in Indianapolis from 8:30 to 2 p.m. So please join that one if you're interested to also connect with the Indianapolis teams. I assume most of the Indianapolis teams will go to that one, but maybe not. I think we want that cross-fertilization between Bloomington and Indianapolis. Also on Friday this week, March 2nd, there will be another scoping session here in Bloomington, also 8:30 to 2 p.m. And more information can be found online on the Addictions Grand Challenge website. Is there anything else that you or Faith, you would like to say to everyone before we let them all go?
So I'm the least data person in here, as you might know from my reaction to the Twitter question. But as I was listening to all of these, I was, first of all, really excited about all that's going on, and also a little confused about all that's going on. And by that, I mean, my governing metaphor right now for what we're doing is a little bit like 6-year-olds playing soccer. If you watch 6-year-olds play soccer, they all run to the ball at the same time, and they're kicking at the ball and kicking each other's shins, and one of them gets her foot on the ball and kicks it out, and there's nobody there to catch it or to receive the pass. By the time you get to 8-year-olds, some of them have learned that if I just stand here, the ball will come to me, and there's a little bit more sort of team approach as opposed to everybody running to the ball. And I think it's a perhaps naive challenge, but an encouragement nonetheless is to ask you all to think together about how we can be less like 6-year-olds, where we are being like 6-year-olds, and more like slightly older soccer players, not all trying to be in the same place at the same time. Where we see overlaps, let's make use of those, and where we see somebody else doing something that was on our plate, maybe saying, you know, I now can move my attention in a new direction that I thought I couldn't go. I know that is contrary to our usual way of doing things, but we need to maximize our resources. And to some extent, I think this is an opportunity, as I listen to all these things, to do that.
And this session was actually designed to have a big round table. It's not perfectly round, actually, but to have all the different teams which do a magnificent work sit together with cookies in the middle and to have them present research to each other that they are currently doing or development products and then start this discussion. I think we have achieved that we have presented quite a number of the major projects going forward. If there are others and you know about them or they become presented in the 2 scoping sessions this week, please also let us know. I think the first step for helping that issue is to know who is working on these data visualizations of addictions data. Second, of course, the phase, I think, is that we should compare timeline, milestones, our stakeholder groups, what we really want to accomplish. And 5-minute presentations really are tough to get that all on the table. But now that we know which teams exist, we can get to them and ask them for the full slide set, which in some cases already had 52 slides, and they were uploaded to Box. And I'm like, well, we only have 5 minutes. It's not going to work. So please do feel free to use the Box we now all have access to upload more substantial materials. Also, Sean Grant, I want to know about that predictive model you had mentioned. It's the very last slide. So please do feel free to share this with all of us. And then we get to this discussion phase, which I think has to happen next, namely, how can we pool our resources so that the sum is greater than the parts? And I think that will take us a while, but we have a nice timeline, thanks to you, on the horizon. And ultimately, it's not just producing scholarly publications, even though the data we now have access to is extremely rich, and I think many, many good papers can be published from it. But at the same time, also truly making a difference on health.
I'll just echo all that and say thank you to everybody who made time for this. I think that we now have some way, if we know there are many other projects going on, I wonder how best to make use of this as a collaborative space, you know, electronically and physically too. What a nice thing.
Yeah, given that the team, so Kosali just mentioned that it will be interesting to arrange these meetups of Indianapolis and Bloomington and other teams. It's not just these 2 campuses. I think it's also community stakeholders and others which need to be involved. And potentially the concept of meetups could be used here to get us to talk more often. And whoever has time at that moment and is interested in that particular topic might come in. And I think it would be interesting to think through how to go from here. On the other hand, I think you're all very intelligent, smart people, and I think you already have your eyes now on certain teams and you want to connect with them, so please do so. And if you need email addresses or you can't find them online, just contact Kosali or Peter MB or myself, and we would be happy to make introductions. So thank you so much for coming out. We are going to end it here for the virtual session. But of course, here in the physical world, we can continue the discussion, and you're welcome to stay online if you want to hear the room, but I think the audio might not be perfect for that. Thank you all on the virtual side for joining us today.
Thank you, Kadi and Kosali, for organizing this.